webinar, Myth-Busting Manual Handling. So I'm just as intrigued probably as all of you are, very much looking forward to it. This does seem to be our most popular webinar ever, so thank you all again. 664 people have booked on, so that's excellent. Thank you for your support, and we trust it's you get some real good things to take away from this session. Just in terms of introduction, my name's George Holbert. I'm the sales director here at Yorkshire Care Equipment. I've been for 15 years, and just a little bit as to who we are. We were established in 1972, so exciting that our 50th birthday is coming up. And our mission is to enhance quality of life, which is really key, I think, and aligns, I'm hoping, with your really, mission and vision, really to lift everybody's and enhance each person's life that we come in touch with. So we do a lot of work with physios and occupational therapists and other colleagues, particularly with the NHS and social services. So we've been working along with them for many years now. Just before we kick off with the main part of the webinar, I thought I'd just like to focus on some of our core products, really, unique products. So many of you will have seen the first one on the left there, the Razor 2. So it gives a very stable lift for somebody who's fallen from the floor and can very safely be used for one carer to help the fallen person up and back onto their feet, and it gives a really dignified lift as well. Razor M, that's a little bit more of a recent one, so really exactly as the Razor 2, but a manual version, hence the M in the name, with the handle there, so wind up handle as opposed to a remote. And then one of our most recent innovations we've brought to market is the Hip Guard. So this is a belt that you wear, a lightweight belt. It detects when you're falling, and then will basically deploy an air sac to the side which you've fallen on, which prevents any injuries to the hips. So that's very unique, really, in terms of the marketplace. These next two products here really focus around hospitals, so seating into hospitals. The Rise and Recline, first of all, on the left, you'll see they're compatible with an Arjo Steady. So often you've probably seen, no doubt, the struggle to use something like an Arjo Steady with a Rise and Recline chair, but you've got the cutout underneath the front of the arms, and it's been designed specifically to work with the Steady, so for rehabilitating patients. And then the ProSpec hospital chair, so very similar, if not based on the original Flowtech chair, which some of you, if you go back far enough, will remember. So you've got the tilt, depth and height all adjustable, so again to suit different size patients, and also to really aid in rehab and speeding up hospital discharge, which we know is a pressing issue current time. And then we've got the Lento family of seating. So we brought out our own care chair probably about 6-7 years ago now. Very adjustable and easily adjustable. So that's the seat width, seat depth, seat height, back height and arm height, again to suit as many patients as we can. And then to replicate the little Lento, so for smaller adults or for children. And then very recently brought out the Rise and Recline chair, which has exactly the same functions as the Lento care chair in terms of adjustments, but also the added benefit of being able to easily upgrade that chair from a single tilting space to a dual tilting space, so saving the need to have to, if somebody's needs changes, to have to purchase another chair. And then all the parts between the Lento Rise Recline chair and Lento care chair are compatible and interchangeable with each other. And lastly, on the products, we're excited about this one because it's just something that we've recently launched in the last few weeks, those of you that were there at the National Back Exchange. So again, extending the Lento range to be part of the bariatric marketplace. So a rise and recline chair with all those adjustments, so seat height, depth, width, arm height and back height, with a 50 stone weight limit, 25 stone weight limit on the leg rest. We can do that as an infection control specification for the hospital market. So we're really excited about that, and that's had a lot of interest since we've launched that. So really enough from ourselves, Yorkshire Care Equipment. Moving on to the main part of the webinar, just really to encourage any questions as we're going through these slides that Simon Love's going to go through for us. Just drop them onto the chat there, and we'll answer those at the end. So a warm welcome to Simon. He's the chair of the National Back Exchange and director of LPS training. So over to you, Simon. Thank you.
Thank you very much, guys, and how wonderful to see so many people here at this webinar. There we go. Let me just pop you on here. So I'm just going to start the slideshow now, and off we go. So myth busting. Let's have a look. So the learning outcomes from today's webinar are to look at current research into the management of back pain and how that's changed actually quite dramatically over the past 10 years or so.
Sorry, Simon, can I just, I think you're sharing the wrong screen because it's not full screen for everyone.
Ah, right, okay.
Sorry.
No. Let's, let me try again then. Share screen. Okay, let's try that. You should see learning outcomes. Is that correct?
Perfect. Yep.
Okay. All right. So
thank you
very much for interrupting there. Otherwise, that was going to get very messy. Thank you very much. So understanding of the dangers of giving the wrong messages. So whether you're out there with family or informal carers, or you're demonstrating it, what messages are you actually giving to people as you're going through any manual handling issues? The importance to use the more current evidence base, obviously, and then at the end, some very positive messages that you can give to people while you're demonstrating, while you're going through any advice for those people caring for others. Very interesting. Pam Simpson, who some people may know, was at the National Back Exchange conference just gone, that was referred to a little bit earlier on. And this is some of her slides, that back pain treatment costs more than cancer and diabetes treatment combined. Obviously places a huge burden on people. And the fact is that almost everybody will have some episode of back pain during their life, of which the vast majority will recover fully, significant improvement within 2 weeks, and 85% are fully recovered within 3 months. So it's unusual to have persistent or chronic back pain. And only a really small number will develop long-standing disabling problems. It's a tiny, tiny percentage of those people who actually have back pain. So I'm not going to do this as a quiz, so there are no prizes, I'm afraid, everybody. What I'd like to do is just for you to quickly think about what you think the answer may be. And it's not to try and trip you up or anything, but it's just something which is of interest to me. So true or false, back pain is caused by damage to spinal structures. So I'm sure you've all formulated some idea here. Let me just talk you through the answer and why. I went to the National Back Pain Show about 4 years ago. I was speaking at it. And yes, there is a show, the National Back Pain Show. It sounds rather bizarre, doesn't it? And there was a fantastic talk by a radiology consultant, and he was talking about the danger of MRI scans. And it's basically because of these reasons here. So these were without back pain. All these people who were scanned did not suffer any back pain. And yet 37% of 20-year-olds will have showed some degree of significant disc degeneration, rising up to 80% of 50-year-olds and 96% of 80-year-olds will show significant disc degeneration with no evidence of back pain. The fact is that disc degeneration is a normal process of being human, and it's going to get more prevalent the older you are, but it doesn't necessarily mean you're going to get any back pain. This is from a study by McCulloch in 2012. This is the same study basically, but this time they were looking for disc bulging rather than disc degeneration. And again, the incidence there follows quite closely the other slide which I showed you about disc degeneration. So disc bulging, disc degeneration, very similar set of figures. This is interesting for me that 20-year-olds without back pain, who should have the fittest, healthiest spines of anybody you would expect, 30%, almost a third, will still show significant disc bulging on an MRI scan. And looking at the total population, you are likely to see these things showing up on an MRI scan with people having no history of back pain whatsoever. So the fact is that if we're sending people for MRI scans and they've got back pain, it is highly likely that it's going to show that they've got some problems with their back, but it doesn't necessarily mean that's the cause of their pain. This is the issue. This is a study by Chung, who studied over 1,000 people on MRI scan. And their conclusion was 90% of 50-year-olds were diagnosed with lumbar disc degeneration on MRI scan. So 90% would have had fairly severe disc degeneration. Other facts out there that you can see from studies: almost a third of adolescents worldwide will experience at least one episode of back pain. Interesting for me, that below the age of 22, so these are athletes, young, fit athletes, will show abnormal changes on MRI scan. And over a third of 20-year-olds will have disc degeneration with no pain shown on an MRI scan. And over 50% of between 20 and 50-year-olds with no hip pain will have cartilage and ligament tears shown up on an MRI scan. The conclusion: back pain and damage are not necessarily related. Interesting. So, next quick question. Here we go. Seeking care for your back pain will help. Okay, I'm sure you've formulated an answer to that. So seeking care for your back pain will help. Well, maybe it won't. Vingard in 2007 did a huge longitudinal study where he followed 17,000 workers for 3 years. So we should be able to get some pretty good abstracted facts from this one then. And what he looked at, and I don't know what his classification of pain grades are, because he graded them pain grade 1, 2, and 3. I presume that pain grade 1 is smaller and pain grade 3 was a more severe level of pain. But those who sought care for their back pain, but they had a level of back pain which was equal with those who didn't seek care, after 2 years' time, those who sought care were still more likely to have back pain than those who didn't seek care. In fact, those who didn't seek care ended up with no residual back pain after 2 years. So that's quite interesting. And the same picture follows through with pain grade 2. Again, you can see the resultant non-care group after 2 years had less incidence of back pain. And the same goes for pain grade 3. So there may be some sort of correlation, and obviously it's quite hard to say from one study. There may be some sort of correlation that those seeking care are more likely to suffer more persistent pain than those not seeking care. And some of the answers may make a little bit of sense as we go through this presentation. Again, a quickie, a quick fire one, true or false: the more treatments I have, the more my back pain will reduce. Okay, I'm sure you've got an idea of this. So the before and after score with a pain intensity score with 1 treatment and with 10 treatments, in fact, the more treatments that people seem to have, the more their pain didn't really alter after subsequent treatments. Just very interesting. I could be doing myself out of a job here if I was still doing my MSK physio work. Okay, so let's have a look at some of the common misassumptions that people may have. True or false, very quickly. Exercise is helpful for back pain. True. There is a correlation between the strength of the back muscles and the strength of the core muscles and the likelihood of having episodes of back pain. So exercise is very helpful for back pain. Question 5, rest is helpful when recovering from back pain. False. One of the worst things that you could do is if you have got back pain is to pad yourself in cotton wool and sit in one of those super Yorkshire Care chairs which look incredibly comfortable and do nothing. Would be in fact very harmful for the recovery from back pain. Exercise can prevent the reoccurrence of back pain. True. The stronger your back muscles are and the stronger your core muscles are, the less likely it is you will have recurring episodes of back pain. Moving slowly will reduce pain. False. It won't. It's a consequence of pain often, and it often lingers way after the pain has gone and the back pain has been resolved. People are still more likely to move slowly, but it's unlikely to reduce the pain. Holding your breath and or activating the core muscles is helpful. I remember many moons ago when I started off doing manual handling, one of the schools of thought is that yes, you need to activate your core muscles as strongly as possible, and you need to hold your breath while you're doing lifting. In fact, this is proven to be unhelpful. So we really don't want you to hold your breath. We really don't want you to activate your core muscles because it will increase the spinal stresses if you do that. Feeling sore after exercise indicates some damage has been done. Well, generally speaking, if your muscles get sore, it means you've done micro damage to the muscles, which will then repair and be stronger afterwards. So in fact, feeling sore after exercise usually means that you've exercised hard enough to have an effect of strengthening up the muscle. It doesn't mean that damage has been done, as in macro damage. Micro damage may be done, but that's actually very positive because it will heal better. Next one, road running can be bad for back pain. There is very little correlation between those who run and the likelihood of having back pain. And it's interesting, there is a school of thought that in fact, if you run on the road, you're less likely to have back pain because you're running on a smooth surface. And if you're running off the road and you've got small indentations in the earth or the surface that you're running on, that will lead to uneven stresses passing up through your legs from the upthrust from the ground, and that is likely to cause more problems than running on a nice flat even surface. Interesting. So breaststroke can be bad for back pain. Generally speaking, unless you've got specific hip problems and the excursion of the movement of your legs during breaststroke, then I can see that that may be a problem. But generally speaking, breaststroke should not be bad for back pain, unless perhaps you're very reluctant to put your head in the water as you swim. So your neck can be extended all the time, and that constant extension of the neck may cause a problem. But generally, breaststroke is actually very good for the back pain. It just gives you a nice reciprocal movement of the lumbar spine without too much excursion. Question 12, drugs are better than exercise in reducing back pain? No. Drugs long-term are generally not very helpful in reducing back pain at all. In the short term, in a really acute episode of back pain where it's extremely painful and you can't move because of the pain, drugs may be helpful in starting to initiate movement, which is so positive. But generally speaking, we want to really try and avoid the use of drugs in a long-term basis because it doesn't reduce the back pain. So interesting, some of the questions there and some of the answers that I've given. The fact is that back pain is multifactorial. Pain is multifactorial. Every person on this seminar now, or this webinar now, will experience pain differently for the same stimulus. That is certainly very true. So why do people experience pain slightly differently? It's because of the multifactorial nature of pain anyway. And some of the basic things which make up how you're likely to experience pain, or how much pain you're likely to experience, or the intensity of the pain, are some of these factors here, which I'll go through. So if we have a look at genetics first, everyone is different size and shape and strength, has different bone density, will have different flexibility. I've always believed that when I played rugby for many, many years, my lack of injuries was due to the fact that I was extremely stiff in the lower back, extremely tight hamstrings, which I think prevented overstretch injuries, and therefore I believe that be why I wasn't injured quite so much. I may be wrong. Muscle dynamics, everybody's muscle dynamics are different. Ligament strengths will be different. They'll be different depending on how much you use that particular joint. And of course, we've all got different aerobic capacity, can all affect how much pain and discomfort we may feel, particularly low back pain. Life stages are interesting. Childhood, when you're growing, going through growth spurts, can affect how much pain and discomfort you're in. Obviously, if you're pregnant, then particularly towards the latter stages of pregnant, you get this cycle of the ligaments become looser and then tightening up again, and then become looser and tightening up again. And obviously, when the ligaments are looser, then the joints can move further with potential problems there. Going through the menopause, obviously, the hormones will change, and the likelihood of injury may change, and pain. And of course, old age, then everything you can become slightly more susceptible potentially. System changes. Sensitivity to pain, really interesting. If you've had pain previously, then the pain nerve pathways virtually become hardwired. So it would only take a tiny stimulus on a pain nerve ending, if you've had it before, actually to be magnified by the time it reaches the brain. So it's not only does it become hardwired, then it becomes much more sensitive to tiny changes in pressure and intention. So interesting. Overreaction of the body if you've had pain previously. So the example I like to give here, if I hovered a needle over your thumb and said, right, in a second, I'm going to jab that needle in your thumb. The first moment you get a tiny little bit of downward pressure on that needle, you're going to jerk your hand out of the way, causing a real overreaction. So the actual stimulus I gave you was probably not sharp at all. However, your reaction would be quite severe. So once you get pain, there's this overall tendency for a real overreaction. And I think one of the most powerful influences of pain is your belief. What do you believe is actually happening? And some examples I could give you. I remember hearing a story many moons ago about an industrial worker in Chicago was repairing a meat freezer where they hang all the carcasses of the beef, etc., in these massive, great big freezers. And he was fixing this freezer. And the door locked on him, and everyone left the factory, and they found him in the morning, and he died of hypothermia, except the fridge wasn't turned on. The freezer wasn't actually working. I heard that story moons ago, and I've been trying to find whether that is true or not, trying to find articles on it, and I can't find any evidence that in fact that actually happened. So that is an urban myth, I believe, but very interesting. I will talk to you about probably the belief system here. So supposing you were up in your bedroom in the evening and you were fast asleep and you heard a crash bang wallop downstairs, you suddenly become scared and anxious. And then you exhibit physical manifestations of fear. So your heart rate is going to go up. You're going to start to sweat. You'll palpitate. You may feel really flushed because you're scared. You go out of your bedroom, you go onto the landing, and you see somebody down the bottom of the stairs carrying your 36-inch TV or whatever it is and going out of the door. So you were scared stiff. So maybe 3 months later, you're laying down in bed again and you hear a crash bang wallop downstairs, and immediately you exhibit the same manifestation of the physical symptoms of being scared because you think you're being robbed again. So again, you're going to start to sweat, your pulse rate's going to go up, you're going to be really anxious, you're going to get flushed, you'll have palpitations potentially. And you go to the landing and you can't see anything, and you go downstairs and you find the cat has just knocked over a vase on the table. So you are associating one event with what is likely to be happening again because you had a belief that you were being robbed, whereas in fact you weren't. So it's actually a physical manifestation. There have been studies out there where they've had subjects and they've been told that they're going to put a really hot coin on their arm. And some of those subjects actually came up with a blister when this coin was placed on their arm. So the body reacted to what they thought was heat and created a blister. In fact, the coin was always at room temperature. So if you believe that something is really hot and placed on you, your body will affect physically to that belief. Very interesting. So if you believe you have back pain for a reason, you have reason to believe you have back pain. And that is a self-perpetuating circle. So it's the beliefs of having back pain are going to lead you to the conclusion that you've got back pain because you've got a reason for it. I remember when I was starting off on my physiotherapeutic career many moons ago now, and I was a very good diagnostician, particularly with back pain. I desperately wanted to give my patients a diagnosis, and I could, usually quite accurately. So I could determine what level it was at, whether it was L4, L5, or L3, L2, or whatever it was. I could do that. I could establish whether it was mainly facet joint related, or it could have been disc related, whether there was some muscular involvement, and I would give the patient all those details because I believed I needed to diagnose what the issue was. I now treat patients very, very differently indeed. I won't give them a diagnosis. I'll just tell them, I'll tell you what, your back is just playing up, isn't it? It's just not behaving. Do you know, this just happens with backs all the time. Don't worry about it. What I suggest is you do X, Y, and Z. So not actually give them a diagnosis at all, but just let them realize that the back is not behaving. And if they did this, this, and this, it would be very helpful. And anecdotally, I haven't made a study of this, but the success rate of treating patients like that, in my experience, is greater than giving them a diagnosis and then doing some physical, like a manipulation or something like that, and then bringing them back again. It just seems to work. So it's trying to disassociate this link between back pain and injury and diagnosis is so important. If you've got back pain, it is without doubt true that you will be anxious because it's going to be painful if you move. So you know it's painful, it's moved, so you're not going to move. And it's very stressful if you've got back pain. The brain will always make the worst out of a situation. Think of the worst case scenario. That's what the human brain does. It's constantly looking for the worst case scenario. And most of the time we're unconscious of it, but what we do is we look for danger, we look for causes of injury, we're looking for this all the time. so we can avoid it generally. And in the jungle, if you didn't do that, you were dead. You'd be eaten by something. So if you weren't constantly looking for that predator, then you would get killed. And I think that's just filtered through now in the human brain. This is what we do naturally, but we don't really realize it. But you're going to catastrophize. Oh God, my back went. Last time this happened, oh, it was about a year ago. Oh, it lasted for months. Oh, this is going to be dreadful. When maybe that's simply not the case. And more often than not, it isn't. You get the sensitization to pain, which I've already talked to and alluded to, that once you get pain, you're going to be much more sensitive to a lesser stimulus than those if you haven't had pain before. So you become really sensitized to pain. You're then going to go through actually quite hard muscle guarding. When I've seen patients and they've had back pain, usually they have a sheet of spasm in their back muscles. And this is partly unconscious and partly conscious, but the body just wants to keep that body part still. And the only way you can do that in the back is to contract those muscles so to prevent movement. And then that leads to, sorry, I've gone the wrong way. I apologize. Oh dear. There we go. That leads to fear of movement, kinesphobia. So you're less and less likely to move if you've got pain for all these reasons that I've talked about. I still hear this quite a lot, and I'm sure most of you will recognize some of these opinions. My back pain is a result of years of lifting wrong. Lifting is dangerous. We shouldn't be lifting heavy weights. Got to be careful how you bend. Bending's bad. Bending's bad for your back. Now, what you should do, you should keep your back straight and bend your knees. My dad was a GP, and when he knew I was getting into manual handling, this is many, many years ago, he said, well, why are you teaching manual handling? All you have to do is keep your back straight and bend your knees. Oh, Dad, things have moved on. Anyway, that was a long time ago. If you do it like this, you'll be fine. You won't get injured if you do it like this. You'll be absolutely okay. Okay, if you just do it, just as I'm about to show you. If you use bad postures, you'll be hurt. Look at the way you're all sitting. It's terrible. Look at you. You're all slumping and you're all leaning and you. No. Some much more recent research by Dave Nolan. Now, those of you who have been involved in the National Back Exchange, or you've been to a conference over the past 6 years, 7 years, will have probably heard David Nolan talk, or actually read some of his articles in our column magazine, which comes out 4 times a year, where there's a lot of research-based evidence there, specifically relating to manual handling. So it's a fantastic resource that you can access if you become a member of National Back Exchange. And David Nolan really has been the champion of changing how we teach manual handling and what we teach, to an extent that he has influenced extremely heavily the Professional Affairs Committee of the National Back Exchange, which has rewritten Health Education England and Skills for Health manual handling training packages. So these packages are going out for anyone who's employed in the National Health Service. And we've changed completely what we've been teaching so that you'll see no reference or nothing to try and link back pain and injury. So there's no mechanics of how your disc bulges and things like that. It's just to do with very positive messages, which I'm also going to give you later on this afternoon. So he did some research looking at manual handling advisors, and he asked them questions based on the 6 following beliefs: that your back is vulnerable, the back needs to be protected, back pain's special. It's different to any other pain. Activity is not safe with a bad back. And the prognosis of back pain is actually poor. And there is a correlation between back pain and injury. So this is what he was asking the manual handling advisors to go through. And interesting that the manual handling advisors were more likely to think that the back is potentially vulnerable and it needs to be protected. And he also looked at this. So from the following 4 slides I'm going to show you, what I'd like you to do is just quickly, and don't think about it too much, just quickly, which do you think is the best way to pick up a box? There are 4 different ways of doing it there. Which do you think is the best way of doing it? Okay. In the answers that he got from the manual handling advisors, the vast majority said that activity 1 was the best way to pick it up. Whereas in fact, there's quite a lot of evidence to show that in fact, activity 1 is no better than the others. There is some evidence that picking up an object with a rounded back is more effective. So activity 3. And each person will have their own way of picking up a box. If you asked 50 people to pick up a box and you took a picture of them, they'd all pick it up slightly differently. And that's because different people are comfortable in different positions. And they're more comfortable with more or less knee flexion and hip flexion. So there'll be a different range of movement in virtually everybody's where they'll start to pick up a box. And I think the key thing here is that what we haven't established is how heavy the box is. So if the box is just a box as we see it, just a plastic box, I always remember David Knoll, when the first time I heard him, he was, there were about 200 people in the room, and he came up to the front of the stage. This was at the National Back Exchange Conference. This is the first one he spoke out there. And he sort of threw a pen on the floor and he said, listen, you guys, I'm going to show you how to pick this up the best way possible for your body. So we're all there and we're all manual handling teachers. And he went down and he just bent down, bent over, stooped over, picked up the pen and stood up. He says, I don't give a damn how you pick the pen up. It's a pen. It really doesn't matter. So activity 3 may be perfectly acceptable if it was just the box that we see. If it was a box with 30 kilos of weight in it, then we may choose to do it slightly differently and work slightly smarter and effectively, and we may choose to do it a different way from activity 3. So there's no right or wrong answer here, but what is true is if we give people advice to protect their back, really need to protect your back, it can be injured, it's vulnerable, etc., etc. There's a sequence of events which is likely to occur. It's probably going to bring about negative beliefs and thoughts about how strong and stable your back is and is it vulnerable or not. It's more likely to bring in negative beliefs and thoughts. It then subconsciously may start to bring about some fear and protective behaviors. Oh, I'm a little bit worried about my back now. The person just told me that it may be slightly vulnerable and I need to protect it, so I better start doing that now. Which, if you do get an episode of back pain, is likely to bring about a continuation of the disorder. So in fact, giving advice to protect your back is probably not the best thing to do. So that protective behavior, does it trap you in the cycle of pain? Good question. If you've got protective behavior, you will exhibit, and this has been shown with lots of research, we have people with pain and without pain picking up an object. They're going to lift more cautiously. They're going to lift slower. So they don't zoom down to pick something up. They're going to do that a lot more slowly. They bend the back less, so you're more likely to see an upright back. they're more likely to brace the core muscles, which in consequence is likely to lead to greater spinal loading anyway. And it's more likely that they're going to experience pain and discomfort if they don't do it that way. So this whole sequence of events, because they can trap people in cycles of pain potentially. So this old adage, keep your back straight and bend your knees. The vast majority of the studies which have loaded spinal segments, very often not out of humans, but out of pigs and sheep. But they've put the spinal segment, which is 2 vertebrae, and the disc in the middle. They've taken it out of a dead body. So it's through the in vitro studies. And then a lot of the studies will actually put the that spinal segment within a pressure plate, and they'll wind up the pressure in various angles of flexion or extension or neutral positions, and see at what point does the disc explode or the end plates crack. And it's not done in human bodies. It's not done in live bodies. So nearly all this evidence has been gained from in vitro studies. So that's taken out of the body. There's been very little correlation between those studies being confirmed in vivo, so that's in the human body, live body. Very difficult to confirm that. There's a lot of very sophisticated machinery out there to try and calculate what they estimate to be the load on the human live body. However, it's still incredibly difficult to do that. There is some evidence lifting with a round back could be more efficient. So if we're dropping little pieces of advice without even realizing it to people we may be showing or demonstrating techniques to, or you've got to be careful, no, you shouldn't do that, you shouldn't bend forward, then maybe we're just adding to unhelpful belief systems which can perpetuate or exacerbate any particular issues they may be having. So when I'm teaching the basic principles of manual handling, it's not to prevent injury. I don't even refer to the possibility of being injured. It's simply to make it easier and more efficient for the caregiver and service user alike if they abide by the basic principles. So if I was going to teach how to lift something very ergonomically and effectively, there are some perfect examples of how this may be done. And if we have a look at this, this video here of a world record clean and jerk weightlifter. Okay. So he's a world record holder, so nobody at his weight will have lifted more weight in the world ever, because at this point he was a world record holder. So he must be doing something pretty good. So let's just have a look through how he's doing this. And I hope this is going to play. There we go. Let's have a look at his position. Now, I don't expect people to pick up a box this way. This is not the reason why I'm showing it. I don't expect any of the people that you may be teaching manual handling. This is not how I'd expect them to do it. But this is how the human body can maximize its efficiency. So there are some pointers which are interesting. If we have a look at the curves of his spine, it's in a fairly neutral position. Okay, so he's not actually flexing forward in the lumbar spine that much. His hips and his knees are in a position whereby he can reach the bar, obviously, but the really strong muscles, the muscles that you really want to get people to use if they're generating a force, the real big guns, the big muscles of the buttocks, of the thighs, of the back, are going to generate the force to lift this heavy weight up. So let's just carry this on because it will spin round again. And it will take him from the front. Here we go. Right, I'm just going to rewind this. Oh no, because it goes in, this is the whole thing, and then it'll slow it all down. If we have a look at that position he's at there, if you notice that in fact he hasn't pulled with his arms are just hanging onto the bar. How do I know he hasn't pulled with his arms? Because his elbows are at the same angle they were when they started. What he's done, he's actually generated all the force with his leg muscles to lift the weight that far. Now that weight now has a momentum which is going to carry on vertically. If we have a look at the angle of his back now, his hips have straightened right up, so he's used his hip extensors, big buttock muscles, and the lower back muscles have generated all the power to get the weight at that height. He's generated so much force that his feet are virtually off the ground. So he's got that down on his chest now, so the whole of the weight is leaning against his upper chest. So leaning the weight, if you lean the weight of anything, means that the muscles will not be contracting as hard dealing with that weight. So he's got a little bit of a rest period here for his arms and his shoulders because all the weight is passing directly through his upper chest. And what he'll do in a minute, again, he's going to use his legs to generate all the force. And only when the bar has extended high enough that he can get his arms straight, will he flick his arms into extension and he'll lift the weight up. So slow motion. Elbows have not bent. So all the muscle power there has been in the legs and the lower back until the bar gets high enough. Then he comes right underneath. Again, the arms are really not doing that much. The weight is actually pushing him downwards, and now he generates a little bit of a 1, 2, 3 lift. The speed that last one was done was absolutely enormous because it had to be, because the arms would never have been powerful enough to lift the weight of the bar from his chest up above his head. So he still had to use the big leg muscles and the really powerful muscles to perform that lift. So positive messages. Positive message we can give people. If we're showing, if we're demonstrating, if we're doing any manual handling, is, in fact, your spine is really strong and robust. It is. It's a really strong part of the body, so don't be fearful of it. Movement is really good. Your body desperately needs movement. If your spine doesn't move, you're going to have somebody jumping up and down on it, a chiropractor or a physio or an osteopath, to make sure it does move. Bending and twisting is inherently okay. It is a really positive movement for the back, for the discs, for everything in the lower back. Bending and twisting is okay. I'll give you a proviso in a second. And if you feel comfortable and confident carrying out a manual handling technique or picking up a box and you do it your way and you're comfortable and you're confident, carry on. There may be no need to change it. However, having said that, if you're bending and twisting, that's fine as a movement, is absolutely fine. I remember after hearing David Nolan, and I was about a week after the conference, I thought, right, I'm just going to follow everything he says. I think this is amazing. I was just so blown away by the evidence he actually gave us, that I was chopping some kindling. So I had a log on a block, chopped a little bit off, and a little bit of a log fell down. So I thought, right, I can bend and twist. It doesn't really matter. I can do that. It's not going to cause any harm. David Nolan said, I'm going to abide by what he said. So I picked up the first bit, right down to the floor, stick it in a basket, job done. Except I repeated it all morning. The next day, I could hardly move. I was in such pain and discomfort down my hamstrings and my hips and the lower back. I was in agony because it was very repetitive. So if you're going to do something and you're bending and you're twisting and you're doing a movement, fine, let's not even worry about it. But if it's very repetitive, let's think about being slightly smarter and doing it differently. If it's a static posture, so you're not only bending and twisting, but you're bent and maybe twisted, and then you stay there for any length of time. Is that likely to injure your back? No. Is it the smartest way of doing it? Nope. We may need to think about doing it slightly differently. And if it's just picking a pen up, does it matter? No. If you're picking an empty box up, does it matter? No, not really. If it's loaded and you're getting towards something which will be heavy for you and you could manage it, is it a smart way of doing it? Probably not. There are better ways of doing it by abiding by the very basic, simple principles of safer manual handling. So, I'm going to stop sharing my screen now, which I hope I've done.
That's excellent. Thank you very much, Simon. A lot to take in there, and very, very interesting research. Really has sort of got me thinking. It's challenging. Now we've got quite a lot of questions which have come in, so we'll
fire away.
Start from the start from the top and work down. I think a couple of the first ones in relation to products, so I will answer those, but looking to you, Simon, for the later ones. So Rachel Jones, rough idea of price on a Razor M. So complete with carry bag and headrest is 1,559, so 1,559. You can get it without carry bag and without headrest for less, but that gives you a bit of an idea. And then Linda Parry, you asked about the hip width range of the bariatric Lento. So a standard, that's from 28 inches to 32 inches. If, of course, larger than that is needed, that's no problem, but that's what the chair is as standard. So moving on to the presentation. So Matt Oakley, he asked Simon, we deal with responding to a choking emergency primarily in the adult care sector. Large proportion of adults in this sector have mobility issues, difficulty standing or unable to stand at all. Abdominal thrusts, Heimlich manoeuvres, requires a patient to be standing for treatment and as such presents an enormous challenge for carers delivering it. Any thoughts?
Yeah, lots. To start with, that is a life-threatening emergency. So I think the to say that you shouldn't assist somebody to stand, I don't think is realistic if it's life-threatening. So you need to be taking greater risks than you would do normally because you can't actually prevent it. If you're doing any technique, it's just really important that you abide by the basic principles of safer manual handling. And maybe we could have another session at some stage and maybe I could go through those in more detail. Well, I haven't actually talked about any really, but I could go through those in more detail. The more force you need to be generating, the closer you need to be getting to the safer principles of manual handling. Some of the principles that the weightlifter exhibited, for instance, in that you should be using your leg muscles as little as possible. I mean, as much as possible, and your arm muscles as little as possible. So all the force is generated by the big force generating muscles of the body. The specific ways of doing that, I would need to show somebody how you're going to do that, but there are actually ways of incorporating the big muscles to do that. It's also possible, I believe, to lean somebody over your knees or lean somebody forward in a chair so you can get at them that way rather than actually have them standing up. I think that's another real possibility. I think for those people who are predisposed to choking, and there are lots of conditions where that may be, somebody really needs to be assessing what the safest way of dealing with that is and giving the care staff who may be responsible for that some ideas on how they consider they can reduce the risk. So there are lots of ways you can attack that, but it's an interesting one. Yeah, certainly.
That's great. Matt just followed that up with, we didn't say don't stand them up. Carers often find it impossible to stand them up at all, rendering 50% of the process impossible. So I think it's any sort of further.
So to lean them forward could be one way. I would have thought. I think you can get somebody quite easily from a chair to the floor. For instance, you may be able to deal with them on the floor when they're lying down on the floor. That could be another possibility. But every person and how they present with that particular issue would need to be individually assessed. And like I say, some sort of plan, some sort of choking plan, I would suggest, which has a manual handling element, would need to be disseminated to the care staff.
That's brilliant. There's some great comments coming up actually from others. Matt, you followed on with that. I'm 6'2" and weigh 15 stone. I cannot pick someone up who's 8 stone plus. But then I think Linda and Helen of Gary have all commented on that. So thank you, everybody, for joining on that one. Question here from Beverly, given this evidence and myth busting, what is the best advice that you would give to carers who often advise that their backs are hurting when using moving and handling, bearing in mind they may be completing on a regular daily basis? She's asking as an OT, hearing this often from carers.
Yeah, I would be wanting to have a look at how they were actually doing the particular activities, and if there was any advice I could give them so they could get closer to the basic principles. So maybe something which they're doing which could alleviate the stress and strain on their backs, for instance. If they've got back pain, lots of ways they could do that. That's one thing I would have a look at. I would like to encourage them to keep moving as much as possible and continue being as active as possible within the limits of their pain and discomfort. That would be the other thing. But really, it would be assessing how they were doing things and if there was a way that they could do it more easily. And the easiest way to do things is to abide by the basic principles of safe and manual handling. So it would be to have a look at that a little bit more closely, I think.
Great, thank you. Katie asked, I'm a patient moving and handling trainer. Can you direct me to any particular book or website that will help with guidance, advice for my courses, please? Some of this information differs to what we've been taught as trainers and like to get it right.
Great. The Handling of People 6th edition is imminently going to be released by Back Care, which is a standard publication for those involved with manual handling. There's lots of advice from the National Back Exchange, who have publications dealing with manual handling in, for instance, the community, in pediatrics, with bariatrics and things like that. There's a whole series of publications produced by National Back Exchange, which may be of some assistance. And the information is changing all the time. And for instance, when I described that the Professional Affairs Committee of National Back Exchange has rewritten the advice from Health Education England and Skills for Health, for instance, in line with the work done by David Nolan, basically. So there's information there as well. And National Back Exchange is a really good resource for people to ask questions. There's a forum there, you can ask questions. You can join your local groups if you do that and get advice from your peers. You're not alone out there. Nearly everybody that you're thinking, if you're part of this team here and you're thinking, oh, I've got a problem with X, Y, or Z, a lot of other people will have very similar issues they may well have resolved already. So to ask for advice, I think is really helpful.
Thank you. Just a quick one, which I'll answer from Emma. Missed the beginning and we've been sent a recording. Yep, we'll get that sent round. And there's an interesting comment, Simon, from Rachel. She really enjoyed it. Actually saw a client this morning with PD, not a textbook transfer by any means, but actually with full risk assessment, it wasn't anywhere near as bad as it initially looked. They were all okay with what they were doing, so we'll carry on as we are. I think it's really important to be flexible and work with individual rather than a rigid black and white approach. I feel like my approach has been backed up.
That is so important, and I'm a lot more laissez-faire about starting to assess whether something is going to be safe or not, the way people do it, than I ever was. But I think that may be because I've got a lot more experience now, and inexperienced people are likely to be more prescriptive, and I think and those with more experience are likely to give more leeway with how people are doing it. And the important thing I'd always stress is everybody should be comfortable carrying out the manual handling, and that for me is really important. So if they're comfortable doing it, I will have a look and see if I can make some small adjustments, but I won't turn around and say, no, you can't do it like that. Simply won't do that now.
Great. And then a question from Laura. Thank you for the session. Are we able to use some of the information directly from these slides in our own training, giving credit to yourselves, of course?
Right, it's not ourselves. Most of that work is part of the work done by David Nolan, and he's been very influential. I'm sure he'd be willing for that information to be disseminated, because he's a champion of just disseminating information rather than holding on to it. But David Nolan, I believe, is working in Sheffield now. Nikki, I know that you will be able to put on the chat exactly where David is working at the moment. Could you do that for us? Great. All right, that'll be posted on the chat.
That's excellent, thanks. And Matt did ask if you'd be happy if you reached out to you, Simon, just following up on the going back to the Heimlich manoeuvres.
Yeah, of course.
And I'm sure, yeah, I'd sure you would be, and for anybody else really out there, it's certainly spiked a lot of interest, debate, opinions. So yeah, I'm sure Simon would be more than happy if you reached out.
Have they got access to my email?
No, but we can include that. Would that be all right?
Absolutely, yeah. And
yeah,
if anybody's got any questions, then I'm quite happy to talk about it on a more specific level with anybody who's got any specific issues. Yeah.
Yeah, and just maybe want to round us off, because conscious we're just after 3 now. Absolutely fascinating. In summary, if you had to give 6 basic principles of manual handling for carers, what would your response be?
What would my response be? I would state that they need to be comfortable. They need to start with the correct stance, which was to have their feet apart basically, and a little bit sideways and front to back. In essence of generating any force, they really need to be moving their body weight with their big leg muscles, rather than trying to move with their hands and arms. They're utilizing the strongest muscles of the body, and you're generating the extra force is generated by the movement of the weight of the body as well. So it's the most effective and efficient to actually move body weight with leg muscles rather than arms. To stay upright as best you can and be comfortable when you're doing it. So there's no need to be bending forward doing an awful lot of the tasks that they may be doing. So to straighten up as best they can and be comfortable in that position. And then wherever possible to try and avoid unnecessary twisting when they're carrying out any manual handling task. Not because twisting will cause injury to the back or the muscles. You can't generate as much force twisting than you can moving forward and backwards. The main big prime movers of the human body are designed to move us forward and or backwards, not sideways. We can, of course, but it's more effective to move forward and backwards. And to lean any load that you may be carrying, holding or supporting or moving, try and lean that weight against you. So if you lean the weight against you, there's huge advantages. And if I get the opportunity of going through the principles in some detail, maybe I can explore this a little bit further, but it's really interesting.
Thank you, that's great. And just to really echo everybody's comments on the chat, Simon, thank you. It's been very, very informative. So just to wrap up the session, just really point you to a section on our website, what we call the online OT kit, not just for occupational therapists, for any therapists and any practicing in the healthcare industry. But really, we put all sorts on there, including a seating ebook, plenty of justification templates, lots of training videos from previous sessions, and a lot more. So just really encourage everybody, dip on there. It's all free. It's really all about helping each other, and use the resource that we put on there. So just to wrap up the session, very much enjoyed. Thank you to Simon, and thank you to everybody for attending. We'll get some the slides and recording round along with Simon's email, and please, any queries, reach out to us, and have a great rest of the day.